videoing?
Yeah.
Hi, Kendall. Should be. Hello. Hi. She's turning it down so I can't watch myself, which is probably Okay. I'll have to remember not to wander too far out of the screen and to speak up. Hopefully the video works. All right, so today we pick up at peripheral nerve endings, peripheral motor endings. We had done the dermatomes. What's important about the dermatome? Ooh, there's another sentence. What is a dermatome? What does it represent? To look at this chart and see.
Where pain is felt.
Where pain is felt, associated with
Spinal nerves.
the spinal nerves it comes from. So this is a map of the skin, bless you, where you might feel different sensations. And this should give you a pretty good clue as to which spinal nerve is involved. I told you guys, bless you, that I was having some problems with my low back. And one of the things that we figured out it was L4 because instead of staying lateral, it actually wrapped around and went to the medial side, kind of crossed over the knee and went to the medial side of the calf. So that's one of the ways was like, no, actually it appears to be the L4 nerve that is irritated. And then we're switching gears to the peripheral motor endings. What are the targets we can have for the nervous system?
Muscles, glands.
Okay, muscles and glands. So the motor endings are going to be reached by the peripheral nervous system. So we're going to have peripheral nervous system. We're going to have those motor nerves that are going to go to the muscles or glands by peripheral nerve. We talked about the neuromuscular junction. Neuromuscular junction is going to have what type of nerve come in? A motor nerve. When we are looking at the skeletal muscles, which division of the motor nerves is going to go to skeletal muscle? Somatic motor or autonomic? Somatic motor. Please remember to put the motor on there. Why? So it doesn't get confused with somatic, sensory. Awesome. So, skeletal muscles. I know we looked briefly at some of the different tracts, and I'm not expecting you to memorize those tracts. But one of the things I want you to understand is from the time we've got the nucleus of the first neuron in the pathway is going to be in the precentral gyrus. You guys remember precentral gyrus? I hope so. You guys seem to remember it on the test pretty well. So precentral gyrus. It's going to go down somewhere along the way. It's going to decussate. And it's going to end up in what part of the spinal cord?
Ventral horn? What are we talking?
Ventral horn. that is one nerve. Not the University of Minnesota, it's the upper motor neuron. I don't even know if they would abbreviate it for Minnesota that way. So, upper motor neuron. Upper motor neuron goes from part of the cerebrum, specifically on the frontal lobe, not prefrontal, precentral gyrus, which is the primary motor area. That's the last place. So that's where the soma is going to be. It's going to go down through the spinal cord. It's going to decussate somewhere along the path, depending on which tract it's following. And then it's going to go down to the ventral horn at the appropriate spinal nerve. And it is going to synapse with another nerve, which the axon of this nerve is going to become part of a peripheral nerve. So if we have an upper motor neuron, what would be the logical second step of the sequence?
Lower.
Lower motor neuron. And the lower motor neuron is going to have its soma where? No, postcentral was upper motor neuron. Where does the upper motor neuron end? The ventral horn. So where is it going to make sense that the soma of the lower motor neuron is going to be? Why would it be in the dorsal horn? Nice try. So we have a premotor, we have an upper motor, and then we have the lower motor, which is going to go to a muscle. And yes, that's my drawing of a muscle. Curved lines, not fancy. So this is in the precentral gyrus. Where it's going to have neurons from the frontal cortex and possibly the prefrontal cortex getting into synapse. This can come down through, what are we going to call the tracks it comes down through? Descending tracks. Goes down through those descending tracks, and this is going to end up in what's this? That's the ventral horn. Ventral horn, gray matter or white matter?
Gray.
Gray matter. So, you're going to get synapses in gray matter? Heck yeah. So where are we going to have our synapse? In the ventral horn. So where's the soma of the lower motor neuron? In the ventral horn. Location, location, location. It's not just for real estate. Okay? And then this is going to go out. This is probably, we just kind of go with probabilities. It's probably going to exit, well, we know it's going to exit through what? Which root? Ventral root. Going to come together to a spinal nerve and break out into dorsal or ventral ramus. Just going on probability is probably going to go down the ventral ramus. And as it comes out, again, running probabilities, it's probably going to go from the ramus into a plexus where it mixes around. And then it's going to come out of peripheral nerve, which will carry it to the muscle. That makes sense? So skeletal muscle, two nerves, two neurons. As a review from what hopefully you remember from the muscle chapter, what is our neurotransmitter at the neuromuscular junction? Acetylcholine. Acetylcholine is going to be released. Well, let's start from the beginning. An action potential comes down the lower motor neuron. What happens as it gets to the axon terminal? Voltage-gated channels open and let what into the nerve cell? Calcium. Calcium triggers what to happen? Exocytosis that releases acetylcholine. The acetylcholine is now free in the synaptic cleft. What's going to happen to it? Okay. Ligand-gated channels, which open for what two ions? Sodium and potassium. Which one does it let in more of? Sodium. So the sodium comes in a lot faster than the potassium goes out. This leads to what kind of potential? Okay, it's a special name. Special name, it's not graded or local. It's two words, an E and a P. End plate potential. Oh, you thought we were done with that. All right, the end plate potential. The end plate potential is going to reach what? Threshold. When it reaches threshold, what channels are going to open? Okay. Sodium, but what opens them? What kind of channels are they? They're voltage-gated channels for sodium, which lets the sodium in, and it lets enough sodium in that it's always going to open the next set of voltage-gated channels. When we have that wave of depolarization, what do we call that? Action potential. Hey, if the dance works, I do the dance. Okay, so action potential. And then, of course, we go through the rest of the story, which is less about action potentials and less about nerves. We go through until we actually get the contraction. So this is a pretty picture, which hopefully you'll be able to follow it along, that you get the calcium in, you get the calcium to come in, the exocytosis crosses, opens the ligand-gated channels, gets enough end plate potential that it will open the voltage-gated channels and get to the action potential. What are the big differences between the end plate potential and a regular graded potential at a neuron-to-neuron junction is it is thought that our neuromuscular junctions will always lead to action potentials. That's the assumption. Fair enough? You look very confused, Preston.
There's no threshold?
There is a threshold, but that it will always be met. That this will always release enough acetylcholine to open enough of the voltage-gated channels that it will always lead to contraction. Providing that there's no disease to interfere with the process. Put that one small piece in there under normal circumstances, which thankfully is what I get to focus on. I don't have to focus on the, oh, and this is how this goes wrong, and this is how this goes wrong, and this is how this goes wrong. That's like pathophysiology. Which, even if you're going to work in the lab, you're going to be studying pathology, so understanding how things work to know how they break, not necessarily a bad thing. Okay, so that should make sense. All right, so visceral. Viscera is what? Internal organs. All right. One of these days, I hope I'm like, what is viscera? And I want you all to say, internal organs. Because that would just warm my heart. Okay. So, they tend to be simpler. The smooth muscle cells, rather than having a neuromuscular junction, they often they have these sort of branches that release neurotransmitters called varicosities. And it's not a direct connection, it just sort of floods a little neurotransmitter here and again, and that can stimulate the smooth muscle to contract. Tends to stimulate kind of a lot of different muscles at the same time. Many smooth muscles have gap junctions between their neighbors. So when they start to contract, they'll have their neighbors contract through those gap junctions. So it's kind of but it's a very slow but coordinated process. Sometimes they will use acetylcholine, sometimes they will use norepinephrine. And obviously, much slower. Any questions? Okay, don't spend a lot of time on levels of motor control. Please. We have different levels that have different patterns, segments, projection, pre-command. Segmental is the simplest. Pre-command is going to be the most complex. You're going to move up through the nervous system with each level. So this is just kind of showing segmental central pattern generators. Central pattern generators can often be things that help you, I think walk. And I go. Because I've got a pattern that tells my legs, these muscles are going to move in this set for walking. So, the type of a pattern. Reflex activity is also down here. I just want to kind of point that out. Reflexes are going to be huge on the upcoming exam. Just saying. Okay, so the segmental level at the spinal, that's like at the spinal cord. Projection level as it comes up into the lower parts of the brain. And then cerebellum, the different basal nuclei in the cortex, modified by feedback. And I guess that must be all I cared about on that. I at least wanted you to recognize the term central pattern generator. This is going to be something you do over and over again that you don't think about, oh, I have to move this muscle this way. You probably did when you were learning. And heaven forbid anything happened, someone was injured and they have to relearn how to walk. You probably have to rebuild that. But for the most part, we build in these patterns of, I know what to do in this situation. Okay. So, reflexes. Most of the reflexes I want to focus on are going to be inborn reflexes, or what they call intrinsic. Intrinsic is something that you're born with. These are involuntary, very predictable. If you have the same stimulus, you will have the same reaction. And I'm walking out of the frame. So, maintaining posture, controlling visceral activities. Even when you go in, you sit on the end of the table and the doctor takes the little hammer and they knock it into your patellar tendon. You guys should all know your patellar tendon. Sorry, patellar ligament. Knocking into the patellar ligament. Acquired reflex is going to be something that you develop over lots and lots and lots of practice. So they're saying driving skills. Knowing which way to practice to turn to get out of a skid. Knowing which way to judging the distance to know. My car and I, we can make that. Yeah, no, I don't think so. Judging that driving distance drives my husband crazy because I'm actually kind of good at it. But I scare him because I'm like, I can make it, and he wants me to do, I can make it. I'm like, I'm not getting a hole that big, honey. It's obviously not going to happen right now. Yeah, I scare him. So what do we have to have a reflex arc? What do we need a receptor for? To detect the stimulus. What is the stimulus? What is a stimulus? How about a change? You think that would be an appropriate but very simple way to think about a stimulus? Is a change. And we need the receptor to detect the change. Does that relationship make sense? Okay, so we're going to detect the change. Once we've detected the change, it's going to send the information to the sensory neuron. And the sensory neuron is going to carry it towards where?
Central nervous system.
Central nervous system. I'm going to focus mostly on things that happen on the limb, or the limbs, which means where is it going to be going? Is it going to be coming up a cranial nerve or a spinal nerve? Okay, it's going to be going to the spinal cord because it's going to come up spinal. In integration center, what's integration? The processing, the thinking about it, deciding if we're going to have a response or not. So, sometimes it's monosynaptic. What does that mean? One synapse. Or polysynaptic. What does that mean? Multiple synapses. Once we've had the synapse, and for these somatic spinal reflexes, what does that mean? Somatic means what?
Body.
Body. Which means our target organ is going to be what? skeletal muscle. Spinal, meaning what? Okay, we're going to have this happen at the spinal cord level. We're going to have a motor neuron. Which one of these do you think it's going to be?
Lower.
Lower motor neuron. Ding, 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 ding. So, the lower motor neuron, and the lower motor neuron is going to go to the skeletal muscle. It'll have the same set of pathways if we are doing a cranial reflex, because there are some that are located in the head. If we are doing a visceral reflex, we have those two. It will actually take us 2 neurons on the motor side, because they have to go through a ganglion, and there's 2. But our stimulus has to be detected, the information sent to the central nervous system where it's processed, and then information sent out the motor side to whatever our effector organ is. This set of 5 does not really change. So, somatic reflexes, these are going to activate skeletal muscles. And the autonomic or visceral, these are going to be smooth muscle, cardiac muscle, or glands. So, something to note. We have, oh yeah, the good old pin in the skin. So we have a pain receptor. You put your finger down on something sharp. That information comes in. It hits an interneuron, and then information goes out to where you're going to prick your hand back. Possibly before, or maybe around the same time as you realize, ow, that hurt. And you stick your finger in your mouth, because that's what we do. So, the receptor is in the skin. It detects the ouch. What's that little blue dot? It would be in a ganglion, but it's not a ganglion.
Cell body.
Cell body for sensory neuron. What do we call the ganglion that it's in?
Dorsal root.
The dorsal root ganglion. So, towards the end of this, it's going to be coming up the nerve. This little piece is going to break out into what root? The dorsal root. This is going to be in the dorsal root ganglion. It's going to come into, what's this area? Dorsal horn. We have our interneuron that goes from the dorsal horn to ventral horn, where it synapses with our lower motor neuron. And this is going to leave the spinal cord through what? The ventral root. The dorsal and ventral roots are going to come together to form what? Spinal nerve.
Oh, yeah.
And the spinal nerve is going to break into
Dorsal and ventral ramus.
dorsal and ventral rami. Well, that's together. So It'll have a dorsal ramus and a ventral ramus. If this information happened to come, okay, you backed yourself into something sharp sticking out in a wall, and it was the muscle back here, the skin back here. Which ramus is going to,
Dorsal.
that's going to be dorsal. If it's pretty much anywhere else, that's going to be ventral. So, when you're very, very, very mean instructor, okay, right here, that'd be me, put something on that looks like that, and you've got a receptor and something that looks like, what she told you was going to be a muscle, you need to be very careful, because this is what? Dorsal what? That's dorsal root. This is ventral root. What's this? Spinal nerve. What's this?
Dorsal.
What's this? Should these come through the same ramus? Why not?
I don't know.
Because one's for sensory, one's for motor.
I didn't say root, I said ramus.
Oh,
Think about that before the test. Think about that before the test.
So what are you asking again? Should what go through
So,
the same?
This has not drawn on anything except this. I'm adding in dorsal root, ventral root, spinal nerve, dorsal ramus, and ventral ramus. So, let's say I walked up, finger on something sharp. That sensory information is going to come up through which ramus?
The dorsal.
Why?
Because it's sensory?
Nope.
No, because it's
Ramus, not root.
your back, so it's ventral.
It's not. It's not the back, so it's ventral. So the sensory information comes in here, comes in through the spinal root. Now we get the
Now you
on-ramp.
go dorsal.
It comes up,
Okay.
processed, out here, back out, and back out to the muscle. Does that make sense? Because that's how I'm going to test you on knowing if you understand the ramus, the spinal nerve, and
This is determined by the region of the body that it's in.
yes.
So the ramus is just the location, and the root's the actual function, right? I mean, in relation to
Roots are
what you're
divided.
saying,
Roots are divided by function.
Yeah,
Spinal nerves and rami are both,
location.
Both
Very
lo-
close to your answer.
but they carry sensory and motor.
Okay.
Because after the ramus, if it's your finger, it'll go through the plexus and then form the nerve that goes to the finger. Branching and branching and branching. Why would we pull our finger back and have our finger off the sharp thing about the time we realized that was sharp and we shouldn't have touched it. Okay, so what's so great about a reflex for protecting us from further damage? Why is it faster?
Doesn't have to go through the brain.
Is it an electrical signal?
It's not all electrical.
Not all electrical.
Chemical here, chemical there. But it doesn't have to take the pathway all the way up to the brain, processing, and all the way back down. It bypasses that piece of the brain. Because if we had to wait for it to say, ow, that really hurts, I should move my finger, it's continued to do more damage. Particularly if instead of having a sharp pin, you've got a hot stove. It's continuing to burn your finger. So, reflex arcs are designed to help protect the body by being faster than sending it all the way to the brain and back down again. Does that make sense? Awesome. So, spinal reflexes, the ones that are going to involve our limbs. And so if I have a spinal reflex, I touch the sharp point, I pull my finger away. Does that still send sensory information to the brain? Of course it does. Because it's going to tell us, yeah, don't put your finger back down there, that hurts. That was sharp, or that was hot, or whichever sensation we got. If you know you're sitting in the doctor's office, they're coming at you with the hammer, and for some reason you're scared this is going to hurt, you can tense up. What's that going to do to your reflex? Yeah, it can stop it because you're going to tense up. So depending on, I will not, you can put the mind over matter thing. Hopefully, if you put your finger on the hot stove and you're not expecting it, this isn't a dare, oh, go burn your finger, you're going to have that reflex. So, if there is damage to your spinal cord above the area of reflex, so I'm just going to go ahead and use the patellar tap reflex. Big difference between patellar tap reflex and the one we looked at. Patellar tap, there is no interneuron. So it goes, this blue comes directly to the red. There's no interneuron in the middle. That's not what I'm going to ask you to draw on the test. I'm going to ask you to draw one with an interneuron. But if you've been in a car accident, you have a patient's been in a car accident, they think there's damage to the spinal cord, they go to do the patellar tap, and instead of just having the normal kick reaction, whoa, they really exaggerated. Chances are good there is an area superior to that reflex that's been completely damaged. Reflexes to the arm, so the tap that you do here will be normal. Tap here kind of causes your arm to go down. You can do it right, I'm exaggerating because I'm just trying to show you what's supposed to happen. If it's absent, that generally indicates that level of the spinal cord is where the damage has happened.
So if the both contain a reflex, would be between the arm.
So if it's normal, if it's, okay, so they went and did this and they got something like that, then it's probably,
knee, but then you got normal on the arm.
that means it's going to be between.
It is between. If you got kind of a over reflex on both, then you know it's probably
Then it's above.
most.
Now, of course, this has to happen fairly soon
Yeah.
because with lack of stimulation, the nerves will begin to deteriorate. The muscles will deteriorate because they're not getting that constant stimulation, and you won't actually get reliable things. But right after an accident, that was something. And I've seen some I've seen some amazing practitioners who are like, oh yeah, it's at this level, just by doing a few reflex things. I'm not that good. I am not a neurologist. But stretch, flexor, superficial reflexes. We constantly get information, not only, what is proprioception?
Where your body is.
Where your body is kind of in space or three-dimensionally. So information about the position of your body. We also are going to be getting information about the amount of stretch from the muscle spindles and in the tendons. So, we told about the patellar reflex, which is the patellar ligament. Patellar ligament runs from what bone to what bone? You thought I was going to let you forget, right?
Ask it one more time, sorry.
The patellar ligament goes from what bone to what other bone? From the patella, it says patellar, so that's a good guess, to the tibia. Actually, to the tibial tuberosity, if you remember me wanting you to know the tibial tuberosity. So, that's the one we tap for the patellar tendon reflex, or the patellar tap reflex. So what is going to happen is when you hit that, it's going to stretch very quickly. It's going to stretch the rectus femoris, a little stretch there. It's also going to be detected in the tendon itself. So, this is just kind of showing how it detects it as it gets pulled. What do you think in real life might cause a rapid stretching of receptors in the quadriceps, particularly the rectus femoris, and the associated patellar tendon, or, well, I guess, yes, less the ligament, more the tendon. What's going to suddenly cause a rapid stretch like they're trying to replicate with the hammer? What?
Yeah, you fall.
Like you're going to fall. What happens when you suddenly trip and you're going to try to catch yourself? You're going to contract your quadriceps. What happens when you're sitting on the table and they bang that hammer? The rectus femoris contracts, and what happens to your knee? Extension! Woohoo! You guys remembered. Okay. So, this is just showing when it's less stretched, fewer action potentials, stretched is more action potentials. So the knee jerk, they're calling it the knee jerk reflex. A stop is trying to keep you upright. If you trip, if you're going to fall, it's going to try to help you catch yourself. And when you're a klutz like I am, I'm familiar with the attempts. Sometimes saves and sometimes failures. But it adjusts it to try to keep you from falling on your face. Kind of a nice thing to have. All right, so reciprocal inhibition. What's inhibition? Okay, to make something not do something. All right, so when we're going to have muscles activated, what are they going to do? We activate a muscle, what happens to it?
Contracts.
It contracts, it gets shorter. So, reciprocal inhibition is going to be if I am tripping and I contract these muscles to try to catch myself, I'm going to relax the muscles on the other side rather than try to slam my knees into the ground by having them go to war. Okay. So stretch reflexes are monosynaptic. What does that mean? One synapse. So the sensory neuron synapses directly on the motor neuron, the lower motor neuron. And it's ipsilateral. Ipsilateral is on the same side. What's contralateral? Opposite side. Why do we test these? We test these to make sure if I've got the right amount of reflex from the knee jerk or patellar tap, that says the receptor works, the sensory nerve is intact, the motor nerve is intact, and the muscle works. So it tests all four of those systems at once. And the spinal cord is intact in that area. So we have the tap here, stretches, comes up, goes directly to the rectus femoris muscle to cause that to contract, but it also does an inhibitory branch to the hamstrings to cause them to relax a little more, which also allows extension of the knee. Does that make sense? And it all happens on the same side. So it's ipsilateral. Okay, I don't have much more, so unless somebody is in dire need of the bathroom, I'm just going to push on. You guys good? Awesome. Okay, so you should be able to follow this picture at home. Yay! Okay. Certain reflexes are going to be absent. Diabetes mellitus, neurosyphilis, where the syphilis goes into the nervous system, and of course during a coma. Diabetes mellitus, when left untreated, or someone has high blood sugars for a long amount of time, it actually negatively affects the nervous system. That is part of the reason it scares me when my mom was like, yeah, I worked at the last part of her working life, she worked at Walmart. And so she was standing still, and she's like, yeah, there's times when I can't feel my feet. That's not actually something I want to hear from you, Mom. You can't feel your feet. One of the big things that they'll do if you are a support person for a diabetic is they're like, you need to have feet check. People with diabetes heal very poorly. If they get a little scrape on their foot, can set up an infection, and they won't necessarily know because they don't feel it. So, yeah, trying to take care of somebody who's...
Is the infection due to not knowing that there's a cut, or reproduction of cells, or both?
It interferes with the inflammatory and immune response.
Oh, okay.
It decreases it. Plus, it damages the nerves. Tends to start at the peripheral nerves. That's why it is a lot less common than I would like to hear about someone who has long-term diabetes mellitus and they have to have amputations because they can no longer feel their feet. And if that gets infected, they may not notice it right away. Whereas generally, you or I would get a little cut on we're going to notice it because it hurts, and it should go ahead and heal. So it's kind of a double-barreled. They don't feel that it hurts, which sets up the infection, and they don't realize how infected it is. Plus, they don't heal, which makes it worse. And if it goes gangrenous, then they have to start amputating. And especially in long-standing diabetics, it's not as uncommon as I'd like for people to say, yeah, I've had to have a couple of toes amputated. I've had to have my lower leg amputated. Yeah, there's lots of
Is that just the?
lots of complications.
Is that just the diabetes itself attacking immune cells, or is that a combination of side effects also from diabetes?
It's the high blood sugar, which is the side effect of having diabetes mellitus. So it has nothing to do with the volume of urine. It has to do with how to describe this. There is a zone in people who have diabetes mellitus where if their blood sugar gets really too high, they will start feeling sick. But there is a zone where it's higher than normal, but it's not astronomical off the charts, where they feel pretty good. And unless they are very, very, very in tune with their bodies to say, oh, my blood sugar is out of normal range, they won't notice anything. So, blood sugar reading of 185. I'm just going to use 185 as this. That's higher than what they want it to be. Probably having something to do with this person drinking sweet tea instead of water or something that wasn't as sweet. And we're talking sweet tea. Okay, curl my teeth, and that's hard to do, to get it that sweet. And this is like Martha Hateful tea. Anyway, family joke. But you can just imagine, okay, and this is way sweet. And that's what he drank last night. He's like, oh yeah, my blood sugar was 185 or 189. I'm like, okay. High normal is 140 or 170. So it's not over the 200 mark, because diabetics, they try to keep them under 200. But that's still too high. So his blood sugar is too high, which means he could potentially be damaging his nerves. But he feels okay. He feels normal for him. He doesn't feel sick. He doesn't feel, oh, I've got really low blood sugar. But yeah, we need to have a big talk about we need less carbs in our lives. And I'm very sorry, but you need to not be drinking that. You need to learn how to drink water. You seriously need to learn how to drink water. And again, that's from personal experience this morning. Yeah, with a diabetic husband. A lot of the information I'm talking about end stage I'm getting from my mom. My mom was diagnosed when I was 18. So that's 32 years ago. Coming up on 32 years ago. And she is the poster child for everything you do not want to do if you're a diabetic. She started changing her diet about 3 years ago. She still eats way too much sugar. It's a good day if her sugar is under 300. And she literally cannot manage to keep her blood sugars low. She has nerve damage everywhere. She's got kidney damage. She can't see. Although they came up with a new injectable that they put in her eyes, and this one she actually gets some clarity for. It's supposed to be good for like 6 months or a year or something like that, instead of going in every month for injections. Okay, so you get problems. Okay, so tendon reflex, this is actually going to have polysynaptic reflexes. Prevent damage from stretching tendons. Why don't you want to stretch a tendon? Why don't you want to break a tendon? It doesn't heal worth a darn. Okay? So, if there's too much tension, this is going to cause the muscles to relax a little to prevent damage. Whoops. So, this is going to come in, and it's going to inhibit a little bit and cause a little bit of contraction to the hamstrings to prevent damage. Okay. So, the flexor withdrawal and cross extension reflex. ipsilateral polysynaptic, so the flexor withdrawal is on the same side, and then the cross extension is going to be contralateral. The example of this that they use, and you can override this where you know that you're going to get a finger stick and you don't pull away when it hurts. You leave your finger there. But the classic example of this is you're walking along the beach and you step on something sharp. What are you going to do to protect your foot from further harm? Okay, you're going to have a withdrawal. You're going to pull your foot back up. In order to pull your foot back up, what do you have to do with your other leg? You have to prepare it to take the weight back. That's all reflex. When you do it by surprise, which I'm not, but you get that. Okay. So crossed extensor is going to be, we have something going wrong with the leg, we're going to pull it back so we can stay standing. So stepping barefoot on broken glass, someone grabbing at your arm, you're gonna try to pull away. So this is the one in your textbook. This is the arms. That if somebody grabs at your arm, you're gonna pull away, and you're gonna kind of balance yourself with the pull away action, or pull and push. So we have the information coming up. You'll notice there's interneurons. So there's interneurons that are going to come down. They're going to activate your flexors. What are they going to do to your triceps brachii? You're going to inhibit the triceps brachii. On the opposite side, we're going to activate the triceps brachii and inhibit the elbow flexors. This is a picture from a different textbook that I have included just to show the true crossed extensor reflex. So you have the ipsilateral contraction just happening here, which actually has pluses and minuses to let you know if it's excitatory or inhibitory. And then contralateral to have you stand up. So I put that one in there so you guys could look at it if you wanted to. So. What I'm going to have you draw, I'm going to have something that looks, well, let's just say I pulled the spinal cord picture from a professional drawing. I didn't draw it, but I've added on the dorsal root. I've added on the dorsal ventral ramus. The important thing is your receptor and your muscle are probably going to come in and out the same ramus. Does that make sense? So there you go. You just got a couple of points for your next test.
And you mean that in the sense of like if you get poked in the chest versus poked in the back, muscles
right.
In relation to the ramus, whether it's anterior or posterior.
So, you know, if you've got a finger,
yeah, it's going to go to the anterior.
Finger's going to go through anterior.
Okay.
It's going to go through the ventral ramus.
Yeah.
If you got poked in the back, you know, you're going to kind of jerk those muscles forward. So
Gotcha.
you basically can choose either one, but just make sure they're the same one. That you don't have it coming in from one and going out through the other. Reminder.